Welcome to the Healthful Woman podcast, the fastest growing podcast in women's health. Today's Monday, October 4th, 2021. Today we start a 6-part mini-series on twins. Yes, you heard me right, 6 parts. So here's the roadmap. Today I'm joined by Dr. Jen Lam-Rachlin to discuss an introduction to twins and types of twins. In podcasts 2 and 3, I'm joined by Dr. Andre Rebarber to talk about prenatal care of twins. Then in podcasts 4 and 5, I'm going to be joined by Dr. Nala Kalick from the Children's Hospital of Philadelphia, or CHOP, to talk about twin-to-twin transfusion. And then finally, in podcast 6, we're going to redrop our podcast with Stephanie Melka on delivery of twins. Think of this as a 6-week mini course on twin pregnancies, and I'm really excited about it. As many of you know, we take care of a lot of twins in our practice, and a lot of my own published research has been about twin pregnancies. And of course, I'm the father of twins. Also on the schedule, we have a high-risk birth story dropping this and every Thursday. Speaking of which, if you did not get a chance to hear our high-risk birth story last week, definitely go back and check that one out. It was somewhat controversial, but a very important one, as we heard from Megan Hofbauer, who told her story of the pregnancy she chose to terminate. For now, enjoy part 1 of our twin pregnancy miniseries with Dr. Jen Lam-Rachlin. Thanks for listening. Have a great day. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Dr. Jen Lam-Rachlin, welcome back to the podcast. How you doing?
Thank you for having me, Nady. I'm doing well, thank you.
You were just begging to be back on the podcast. You kept harassing me. I said, Jen, come on, enough already. Yeah,
you know me, I love speaking.
You love speaking. So you're moving farther and farther away from me. So you're now 60 blocks away from me and I had to call you. But you can run, but you can't hide. The podcast will always find you. But no, I do appreciate it. And we were going over potential topics and we both thought that this would be a good one because, we see so many twin pregnancies and people know someone with twin pregnancy or they have a twin pregnancy, but people don't really sort of think about what we're thinking and how do we assess what kind of twin pregnancy and what does that mean? And there's a lot of confusion. So we thought it'd be a good idea to try to, maybe clear that up and help people understand how we think about twins to maybe get a better sense of how we may manage them differently.
Yeah, I agree. I think it's an important topic. Obviously, we see a lot of twins, and there are a lot of confusion in the, available literature for patients. And I feel like I do spend a lot of time during my consults with them to clear up some of the confusions. A podcast like this would definitely help.
Yeah, for example, there's all these different ways. Are the twins identical versus not identical, which is what people hear, or maternal versus fraternal, or are there 1 placenta or 2 placenta? All these things, and how are those related? And we're going to try to sort all that out. So it's a little ambitious, but I think we're going to do it. And I think this, twins are such an interesting topic that, this is really just like step 1. We see someone and evaluating for twin pregnancy. This is literally the first thing we do before we make any more of the plan. So I thought it'd be a good place for our podcast to start. Just for some background, twins are common. Right now, it's about 1 in 30 births, although it seems in, patients I see, it's like 1 in 3.
Yeah.
We see a lot of twins. And they are more common as women get older. They're more common with fertility treatments, also with family history. And in terms of different ways to think about twins, let's first start with idea of like the genetics, this identical versus non-identical. So what does it mean for twins to be genetically the same or different?
I think most people that's not in our field would kind of classify twins as either are they identical or they are fraternal, which basically means identical twins, they are genetically the same. They started off as one unifying cell and it's split into twins. So genetically the same versus fraternal, meaning that they are genetically different, right? So it could be that 2 eggs were fertilized and there were 2 different pregnancy kind of coexisting in the same uterus. As you know from our field, it's less important to know identical versus fraternal, more important to know how many placentas, how many sacs.
Yeah, I think that's one of the things that people find surprising, that we we always talk about whether we think they're identical or not, but it really doesn't matter that much to us. And, in terms of just when I try to explain to women sort of how do twins come about, right? In terms of like naturally, let's take fertility treatments aside. There's really only two ways. The first way is sort of you have one egg and one sperm, right? And they meet. And that's, one pregnancy. It's a zygote, as it's called at that time. But basically, it's going to be one baby. And then that splits into two. And that's how you get identical twins, or what some people call maternal twins. Sometimes we call them monozygotic. These are all fancy terms for twins that came from the same, one, it's not really a baby at that time, it's an embryo or whatever, but it splits into two. And that's why they have the exact same DNA. Identical twins have the same DNA because they came from the same egg and the same sperm. And the interesting thing about that is that event where one embryo splits into two, it's the same across all populations, the likelihood of it happening. It's not affected
Right.
by family history. It's not affected by age. It's a completely random event, which is really interesting just from a scientific standpoint that it happens in the
Yep.
same frequency.
Exactly. The frequency hasn't changed in the monozygotic twins, which
Yeah.
is very unique in and of a. It could be a whole topic in and of itself of why it occurs.
Yeah, the only exception is actually for women who undergo IVF. Even though there may be one embryo put inside the uterus, that embryo is more likely to split than in nature. Meaning in nature, it's about 1 in 300. But with IVF, it could be 1 in 30 or 1 in 40. It could be 10 times higher. So it's not that it commonly happens, but definitely much more frequent with IVF pregnancies. And so we always warn women if they're having IVF, even if you're only putting one embryo, sure, that's going to lower your risk of twins a lot, but it doesn't make it zero. And, again, it is really interesting. Identical twins, all this, sort of socially, it's very interesting. They look alike, they think alike, do they have this, special connection and whatnot? But we don't really get into that. It doesn't really matter so much to us, except if we're trying to like diagnose, genetic, conditions or not. We'll know they'll be the same or different. The other way people have twins is that there's actually two different eggs and two different sperm. And it just happens to be that the mother ovulated two eggs that month. And that is genetically related, right? So when you ask women about a history of twins in the family, you're talking about that kind of twins. And those are the twins that we call either non-identical or fraternal or dizygotic. These are all the same thing. And they're genetically similar like siblings.
Technically, they're like 50% genetically normal, 50% not. But yeah, so they act more like siblings, only obviously they're the same age, the same conception date.
Right, and they share the same uterus.
Yes.
And now the way this would be impacted by fertility treatments is if you're having IVF and they put in more than one embryo, sure, you may end up with non-identical twins. Or the other ways, if people have fertility treatments not related, they don't have IVF, like they have other treatments like hormonal. So what happens there?
If they have a non-IVF type of hormonal treatment, those type of treatments help patients ovulate, right? You have to ovulate. You release the egg to get pregnant to meet up with the sperm. And when they go through hormone treatments, sometimes they ovulate more than one egg. Let's say, for instance, they ovulated twice, and there's two eggs that get released, and both of those eggs can get fertilized by different sperms, and then resulting in twin pregnancies. Worst case scenario would be if there were more than two that ovulated, and then you have these higher order multiples, right? Like in triplets and quadruplets, which thankfully has been less likely to occur given kind of the changes in terms of monitoring for these fertility doctors.
Yeah, it's interesting. I think that there's a misconception out there that for, like Octomom and people who get pregnant with, 5, 6, 7 babies, that the thought was that the IVF doctor put in 5, 6, or 7 embryos. But that's almost never the case. The IVF doctors are going to put in 1, maybe 2, in the old days, maybe 3. The way someone got pregnant with 6, 7, or 8 was they got injected with a ton of hormones and then just went off on their own. And
Right.
they happened to ovulate 6, 7, or 8 times in that cycle. And that was really how it happened. So people are getting these hormones typically are monitored to make sure they're not going to ovulate that many. So again, that distinction about whether twins are genetically the same, genetically not the same, as we said, is not really important to us. So what is it that is important to us in terms of twins?
Yeah, most importantly for us is it's how many placentas, how many sacs, is there a separating membrane, or are they in the same sac, same uterus, same placenta. I think placenta, sac, uterus, they're kind of very abstract terms, patients that are not in the medical field, right? And the best way that I would describe it is, something called a dichorionic diamniotic twins, or two sacs, two placentas, or kind of the best analogy is two siblings twins that live in the same apartment complex but separate apartments, right? They have their separate kitchen, they have their separate living space. They should not be in competition with each other in terms of nutritional source and space, versus monochorionic twins, which share the same placenta. So it's like as if they live in the same apartment itself with one shared kitchen. So there could be competition of nutritional source. If they're monochorionic but diamniotic, they have two separate sacs. And so it's like they have like two separate bedrooms versus, mono, which would be like living in a studio apartment with a twin pregnancy. Obviously much more complicated compare as we go along down that line. And kind of the highest risk of twins would be obviously conjoined twins, and the degree of where it's conjoined.
Yeah, I think that's a really good analogy. Most women have one uterus. There are some with two, but basically one uterus. So both babies are in the same uterus, but the placenta is sort of the thing that nourishes the baby. So it takes food, water, oxygen, all this stuff from the mother to the baby, or in this case, babies. And if they each have their own placenta, it's like each having their own refrigerator or kitchen, like you said, each have their own food source, and they're not directly in competition one to the other. So it could be that one gets more and one gets less of, let's say, one placenta works better than the other. That happens a lot in twins, but it wouldn't be that if one, like if you and I are sharing a refrigerator and I take a lot of food from the fridge, you have less, right? And so, whereas if we each have our own refrigerator, it's different. And so that's a really important one with the placentas. And it is basically about supply of either food or water, sometimes even blood specifically. There's conditions if they share a placenta. And then what you're talking about, the rooms, that's the water bags, right? So the water bags is really just everyone's got their own space. And the reason that matters is if the twins are in the same water bag, which is unusual, but when it happens, they're swimming around each other and their cords can get entangled. There's no separation between them, and that has its own set of problems. And so, so we look at that, and that's really all we're thinking about. Now, it happens to be that there is a relationship between those two, between how the placentas and membranes are organized and whether they're identical or not. But again, it's only the case that, one sort of implies the other sometimes, but it doesn't really matter to us if they're identical, meaning you can have identical twins who share a placenta, and you can have identical twins who don't share a placenta. And the bigger issue with us is whether they share a placenta, not whether they end up being identical or not.
Yeah, I think the most common misconception is, when someone's told that they have di twins or two separate placentas, two separate sacs, that means that they're fraternal, and that's not always the case. They could still be identical. But from a monitoring perspective, it doesn't really change how we do the monitoring.
Right. I actually have friends who, growing up, were clearly identical twins. I mean, looked the same, talked the same, thought the same, acted the same. They were like, no one could tell them apart. And they're like, no, we're not identical. We're like, get out of here. Of course we're identical. They're like, no, we're not identical because we had two placentas. And in high school, you're like, oh, that sounds pretty scientific. I guess you're not identical. Then I went to medical school and I learned this. I was like, aha, you're definitely identical. I knew it. Yeah. I knew it all that time. I suspect they knew it too, but for some reason didn't want to admit it. So let's talk about the way we think about it. Like you said, that the least risky of all twins, right? All twins are higher risk pregnancy, but the least risky of all twins are, like you said, the ones where there's two placentas, meaning each baby has his or her own placenta and his or her own water bag. And we call those dichorionic, meaning two chorions or two placentas, diamniotic, two amnions or two water bags. Unfortunately, the shorthand for that is di, which sounds horrible. We're like, hey, you have di twins. And people are like, what? Like, what are you saying? Like, no, di. Just like, not, listen, we could tighten that up and make it better, but that's just how it is. So that's the lowest risk type of twin. So if you see pregnancy, and we'll talk about how we know this, and you say, all right, there's two placentas, two water bags. So what do you know? So can you know for sure whether they're identical or not identical?
In general, no, unless they're different genders, right? If one's a male, one's a female, then for sure they're not identical. But if they're the same genders, like two boys, two girls, there's not really a way that's 100% foolproof to say that they're identical versus fraternal.
Right.
There are genetic testings, whether via screening tests or invasive testing, that tries to tease out whether they are genetically the same or not. But obviously there are limitations of some of these testings.
Yeah, that's been very interesting for us because, we'll see people with twins and again, that 2 placentas, 2 water bags. And, let's say they're, it's too early that we don't know whether it's a boy or girl yet. And we would usually think that they're not identical, but sometimes they'll say, oh, I had IVF and they only put in one embryo. We're like, oh, then they probably are identical. Or there is this blood test now that can give you prediction of whether they're identical or not. And it's pretty accurate. It's not 100%, but it's a lot more accurate than you would expect. I mean, it's really very good. But again, it tends to be the lowest risk, and you can't tell for sure whether they're identical or not. And so those twin pregnancies we sort of manage as our standard twin pregnancies. And the nice thing is there's no competition for food or for water in terms of one taking from the other. And also in those types of twins, if unfortunately something happens to one of the babies, it won't affect the other. They're literally just sharing, like you said, an apartment complex. They're not even in the same apartment, they're in the same building.
Right, exactly. Mm-hmm. So from all the twins, these are quote unquote the best type of twins to have because they are the lowest risk of twins.
Right, exactly. So that's what we call di-di or dichorionic diamniotic. And the next level is when they each have their own water bag, so they're in their own bedroom, so to speak, but they share one placenta. So we call that monochorionic or one placenta, diamniotic, 2 water bags, or monodi, which is what we call them. Again, a little bit gruesome, but that's what we call it. So why does that increase the risk, right? What can happen in that kind of twins on top of what could happen in the first set of twins?
Yeah, so aside from just general twin complications, they're sharing, as you said, the same nutritional or same blood supply. So there could be competition of one getting more blood than the other or more nutrition than the other, and really related to just how much sharing of our equal or unequal sharing of that blood supply, and can translate into more complications, such as twin-to-twin transfusion syndrome, which is something that we talk about a lot for monodi twins. But there's a variety of different other nuances aside from TTTS, but it's all related to geography of how much placenta they have or how much blood flow they get.
Yeah, and that's a really important distinction because we're always worried about, like you said, all twins. There's a risk of preterm birth and the risk of how they're going to grow and a risk of diabetes and high blood pressure. All these things there's a risk for in twins. But when they have the same placenta, on top of that, we have to follow for those problems that are unique to having the same placenta, like you said, this twin-twin transfusion. And we're gonna have a separate podcast on that alone, so we don't have to go too deep into it. But it's a problem, and it happens in 15% of these kinds of twins. But we have to monitor for it because it could be pretty serious. And one of the interesting things is essentially 100% of the time, if you see one placenta, they are identical, right? It's almost impossible to get one placenta from non-identical twins. It's been reported, but basically it doesn't happen.
Yeah.
And so for our end, we sort of know that. And also if you are going to do genetic testing, it should be the same, one versus the other, almost always, essentially. That is a higher level of risk. And not a lot of people know that coming in to their twin pregnancy. They think all twins are the same. And these are clearly everyone, in our world, those are way higher risk than the first set of twins.
Yeah, I agree. Aside from just the sharing of the placenta, as you kind of alluded to with the di-di twins, if something happens to one twin, generally the other twin is not affected. But in monochorionic twin pregnancy, if something happens to one twin, it can affect the surviving twin because they do share that blood flow.
Yeah, and that is a unique circumstance. Fortunately, it's rare, but if you have situations in pregnancy where, let's say, and it happens where one twin is thriving and doing great, and the other twin is just not. There's something wrong, either something genetically wrong with the baby or something, let's say the placenta's not working or something's going on. If they don't share a placenta and something happens to the first baby, let's say the first baby passes in utero, it dies, it won't directly affect the other baby. It's very sad, but it won't directly affect the other twin. But if they share a common blood supply and one of them dies inside, essentially there's a huge pressure shift in the blood flow and there's a very high chance of it affecting the surviving baby. And so we don't have the same options of like, let's wait and see necessarily that we would have if there's two placentas. Again, these are not common things in twins, but it's very important on our end in terms of counseling people what to do to know if they're sharing a similar blood supply or not. And tell me about why is it such a problem if they're in what we call mono, meaning one chorion, monochorionic, one placenta, and also monoamniotic, one water bag. This is where the two of them are in the same studio apartment. So why is it such a big deal if their cords are getting wrapped around each other?
Well, that's primarily where they're getting their blood supply from, their oxygen, their nutrition. So if you can imagine, like literally like two ropes tangled up together, you could cut off some of the blood supply to one or both twins. So there's a higher risk of losing one or both.
Yeah, and these pregnancies are like crazy high risk. They're fortunately rare, but these are kinds, the risk of stillbirth is so high that either by the third trimester, we're admitting them to the hospital and watching the babies continuously. That's what we do in our practice typically. There are others who just see them in the office every single day for testing, like literally like 5 days a week, 6 days a week, 7 days a week or something. I mean, they're watched so frequently because there's a chance of something happening. They always get delivered early. I mean, they're going to be preterm. Even if everything goes perfectly, we're going to deliver them early before something terrible can happen. And also just one of the sort of the way that identical twins can get different kinds of placentas, right? We said identical twins can have two placentas, they have one placenta, they can have the same water bag, is sort of based on how far along in the embryonic development does it split. And the later it splits, the more they share. So also the later they split, the higher the risk of birth defects. So the twins that share the same water bag, it's not because they share a water bag, they have higher risk of birth defects. It's because they split late, they share a water bag, and they have a higher risk of birth defects. So there's a very high chance these babies having heart defects or whatever, and it's makes it on top of the high risk pregnancy a very high risk pregnancy. And so these require a lot of counseling early on if people are ready to embark on this.
Correct.
Yeah, how often do you see that? I would say, and you know, because you're an ultrasound and you see a lot of pregnancies come through. Is that a conversation you have once a day, once a week, once a month, once a year? What would you say?
For mono twins?
Yeah.
Kind of generically, I would say it's very rare. It would be like once or twice a year that we would have that counseling, because it encompasses like maybe like 1 to 3% of all monochorionic twins.
Yeah.
So it's quite rare.
Yeah, it is pretty rare. And what sometimes happens is, and this is sort of one of the nuances, if the ultrasound is done very early, you can't always see that membrane that separates the two twins.
Mm-hmm.
Like you can't see that they're in two water bags because it's so thin, you can't even see it on ultrasound. And so sometimes people will have an ultrasound at 6, 7, 8 weeks, and either us or the outside doctor will say, oh, you know, I know they're twins. I see two babies, two heartbeats. It seems like there's one water bag. I don't see two water bags. And they come to us to talk about that. And then by the time they're like 9, 10 weeks, we say, no, we can see the membrane between them. There's actually two water bags. That happens a lot. I would say we see a fair number of those consultations that end up, fortunately, just being the medium risk, high risk twins with the one placenta and two water bags. When would you like to do the ultrasound to determine how many placentas, how many water bags there are?
The earlier the better, but we should definitely be able to see placental membrane by 9 weeks of pregnancy. So aiming for at least a scan between 7 to 9 weeks, I think, is a great time. Doing a scan earlier, we don't necessarily see the membranes or the placenta yet, but it can give us a good idea because we can see how many gestational sacs or how many yolk sacs. So I don't think there's ever a downside of doing an early scan, but to clearly identify membrane and placenta, I would say ideally around the 9-week time period.
There's uncertainty sort of nationally and internationally. Should every pregnant woman get an early ultrasound, like in the first trimester? And on the one hand, some people say, well, most people don't need it. It's a waste of time. It's a waste of money. You're increasing anxiety, resources. Okay, and that's true for many people. But this is one of those situations where it changes everything. Meaning if we have an ultrasound at 8, 9, 10 weeks and we diagnose that it is twins, right? Number one, we'll figure out it's twins. Number two, we'll have a very high confidence of what kind of twins it is. Whereas if someone doesn't get ultrasounds, let's say, and they show up at, at 20 weeks when they're going to get their anatomy ultrasound, their doctor or midwife's like, hey, yours is measuring a little bigger than I would think. Why don't you get an ultrasound now? And we see him at 20 weeks and there's 2 babies. We can't tell at that time necessarily if, what's the story with how many placentas, the membranes. It's much, much harder. And it really changes everything we do for the rest of the pregnancy, knowing what kind of twins it is.
Once you go beyond the first trimester, especially for placentas that are in the same location, right? It's very hard to tell whether there's 2 separate placentas. It's really hard to tell, is the membrane dividing them thick or thin? So definitely you want to aim for a scan and sometime in the first trimester, ideally again around that 9 to 10 week window.
Yeah, I totally agree. And it's one of the reasons, listen, our practice, we do a first trimester scan on everybody. We do, whatever, full disclosure. And number one, we want to see that there's a heartbeat. Pregnancy looks good. I rarely encounter a patient who doesn't want us to check these things. And then obviously we want to know if it's twins, and if it is twins, what kind of twins. It really does change our management and our counseling, in terms of what's the prognosis, what to expect, when are they likely to be born, all these risks and what tests we can do. It totally changes throughout the pregnancy. There's a lot of press given to conjoined twins, what used to unfortunately be called Siamese twins, but they're conjoined twins. That's the term that we use when twins are actually, quote unquote, like stuck together. So what is that? What's going on there?
So, this is the same idea. It started as one zygote that divided, but divided very late. So they do share the same placenta, but aside from sharing the same placenta, they have shared, organs, right? They're stuck together on a variety of different attachment points where they can share certain organs. Obviously, that translates into a much higher risk pregnancy, but also thankfully very rare.
Yeah, that's really, really unusual, but essentially it's the latest splitting they can do that's not even complete. It's like an incomplete splitting, and based on exactly, there is no one way to look at these because, based on how they're connected and what they share, it'll change whether they may or may not be able to be separated after birth, and if so, will they both survive? Will only one survive, right? There's different ways. If they share a heart, then clearly they can't be separated and have both survive because each one will need a heart. If they're sort of, connected at the shoulder, all right, then you can sort of try to sort that out. And again, fortunately, this is, not even once a year. We have a consultation for this. Only a handful over my whole career, I would say.
You usually diagnose in the first trimester too. So it kind of gives the patient, a lot of information early on to decide what to do with the pregnancy.
Absolutely. So just to review, this is what we think about is sort of placentas, membranes, right? What's going on there? Are there 2 placentas? Are there 2 water bags? And, the lowest risk type of twins is what we call di-di or dichorionic, 2 placentas, diamniotic, 2 water bags. Most common kinds of twins, usually not identical, though sometimes they are identical. And there are definitely risks in twin pregnancies, but it's sort of just twins. And then the next level is 1 placenta or monochorionic, but 2 water bags, diamniotic. Higher level because they share the food supply, the blood supply, and one can take from the other. And then the next highest level, which is much more rare, and sorry, those are always identical. And then the next level, which is much more rare, also identical, where they share the same water bag. And then the most rare is where they're actually conjoined. Wow, we did that. That was pretty thorough. I like it. Excellent.
So very brief synopsis on twinning.
Yeah, this is twinning, and this is really, I think, a good introduction because when we do podcasts on prenatal care twins, on twin-twin transfusion, I think it's a good primer for people to know sort of how we think about this and why we would, why is twin-twin only relevant in one kind of twins but not in most kinds of twins and so forth. Jen, thanks for taking time out of your day and coming to the podcast. I appreciate it.
No problem.
Even though
I
keep twisting your arm to do it more.
No, it's a pleasure. I enjoy doing it.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.